assisted ventilation of the newborn. I am Elahe Amini, neonatologist. This session from Goldsmith. Here we have a patient that needs more than 60% FiO2. We should correct respiratory acidosis, anemia, arteriovenous difference of oxygen, and all kinds of shock. And after that, for example, we prescribe for patient CPAP or all that the patient may need that. And if yet the patient needs more than 60% FiO2, we should think about right to left shunt. So we are interpreting this graph very briefly that shows right to left shunt at different FiO2 with a patient with normal heart structure. We have three curved lines here. First of them at 60% FiO2, and when we increase to 80% and then to 100% FiO2, we see that from horizontal line, if the patient has a 30% right to left shunt, there is no increase in arterial oxygenation that is shown here on the vertical line. So when we increase the FiO2 of the patient, it is very harmful, and if the patient hasn't any increasing in arterial oxygenation or SpO2, it shows that the shunt, the right to left shunt, it is more than 30%. So we should do another thing. Where is the place and the anatomy for right to left shunts? It is at the foramen ovale, that almost always in the fetal period and after birth is right to left. The second one is at ductus arteriosus, like in fetal period. And the third one is at the alveoli. It means that blood goes through the alveoli without gas exchange. And if this shunt is more than 30%, increasing in FiO2 can't help the patient, and hypoxemia is persistent. So we should decrease the right to left shunt with decreasing pulmonary hypertension. It is very important. We should decrease pulmonary hypertension. So in this graph, we don't have respiratory acidosis, and we don't have any anemia or hypoperfusion. We correct all of them, but the patient has hypoxemia. What is the meaning of arteriovenous difference of oxygen content? Oxygen content is a volume of oxygen in our blood. For the arterial part or every place, the formula is the same, but the difference is very important. Oxygen content equals 1.34 milliliter times SpO2 times hemoglobin, plus 0.003 milliliter times PaO2. It means 1 gram of hemoglobin is bound with 1.34 milliliter of oxygen, but not all hemoglobin is bound to oxygen. So we should times SpO2. And in the other hand, we have for every millimeter Hg of pressure of oxygen in the blood, it has a volume of 0.003 milliliter. So every pressure of oxygen has a volume equals 0.003 milliliter of oxygen. Arterial oxygen content in normal situation is about 20 milliliter per 100 milliliter of blood, and at the venous oxygen content it is equal 15 milliliter per 100 milliliter of blood. So 20 minus 15 equals 5 milliliter, the amount of oxygen that is consumed by the tissues. It shows that it is normal with a normal volume, normal perfusion. But in hypoperfusion, all kinds of shocks, cardiogenic, hypovolemic, septic, the difference is larger than 5 milliliter. A question for reviewing. Arteriovenous difference for volume percent. What is the meaning of that? The percent. The first choice is per 100 milliliter of blood. Second choice SpO2 percent. Third one respiratory quotient. Fourth blood pressure. The correct answer is choice per 100 milliliter of blood. What is the meaning of respiratory quotient? Respiratory quotient is CO2 production for every unit of oxygen consumption. In normal situation that we have a diet mixture of protein and carbohydrate, it is equal 0.8. But with a patient that is MPO and we prescribe only dextrose water, it is equal to 1. So in respiratory failure, it is very bad that we have only carbohydrate diet, and we should prescribe from the first day of life protein with carbohydrate, parenteral nutrition for decreasing CO2 production and helping patient with respiratory failure. Next session we speak about other issues of respiratory physiology. Thank you for your listening.